cases of metabolic disorder in the future. So we are prospectively following them up. It's a longitudinal study design, right? So that's your prospective cohort study. Now, as I mentioned before, so the cohort should be disease-free at the beginning of the study. Remember the timeline, when you screen them, there should not be the disease state that we are interested in or the outcome that we are interested in. Same baseline information collected from all subjects in the same way. Always please remember that whenever we are conducting a cohort study, it is very important to look at the baseline info. So that is when the screening started. What their age is, gender, race, ethnicity, what comorbidities did they have. Did they have any particular medication that they were using apart from the main medication that we are interested in? So these are all the different information that we need to collect from all the different study participants in the same way, and then obtain accurate information about exposures prior to the disease development in any of the subject. This is very important, like when was the exposure, the time point where the exposure started, and when the outcome finally developed later on. And as I said before, the patients are longitudinally followed over specified time period to determine if and when they contract the disease and whether the exposure status changes. So what can happen is some people who are not using the antipsychotic at the beginning, they can start using them later on. So there is many different ways how the dynamics can go on and how you analyze them. So these are some very important concepts to keep in mind when you are working your way through in this way. And some people who are started using antipsychotic, they may stop using antipsychotic. There is an adherence problem right there. So many different things can happen as you move forward in your timeline. Then, in terms of it's important that the investigators can eventually use this data to answer many questions about the association between risk factors and disease outcomes. So this is very important, like, what is the treatment or the exposure and what is the outcome and how are they related or associated. And please note that we cannot establish causality. We can only establish association with this kind of study design. That's why it is considered inferior to the traditional randomized controlled trials where you can actually establish cause-effect relationship, right? The causal inference that can be established. So, having said all these things, what are the advantages and disadvantages of prospective cohort study? The advantages are that it indicates the temporal sequence between exposure and outcome, because we are going from one point to the other, to the future point, and we are trying to follow them up as completely as possible. So we know when the exposure started and when the outcome happened. Can evaluate multiple effects of a single exposure. So for example, for the antipsychotic exposure, we talked only about the metabolic disorders, but they can have mortality. There is a risk of mortality with antipsychotic use in certain age groups and in different populations and all. So you can also look into mortality. That's another outcome that you can look into. Hospitalization, that's another important real world outcome. So you can look into them as well. These are very efficient for rare exposures and outcomes with long induction and latency period. So it is not something like, it happens right away. It takes time for that outcome to happen once you start using that particular medication. It doesn't happen like you start getting those metabolic disorders right away. It needs maybe 6 months, maybe 1 year time, maybe 5 years time. So that long induction and latency period is where this kind of study design is very useful. However, the disadvantages of this kind of study is that it is expensive. And let me add, it's super expensive in many cases. It's time consuming. So you can think like, if you are following them up for such a long time, it's time consuming. And another important problem is loss to follow up or attrition bias that happens, because as you move forward in your follow up, there are many people who will not show up, Many people will pass away, die, or they may move away for many different reasons. So you are not able to follow them up properly. You lose them. So these are some of the disadvantages of your prospective cohort study, right? So one example, and you can read this later on when I share the slides with you, but this nurses health study, this is like a landmark study that started maybe in started in 1976, right? And it has been going on since then. And if you look at the total cost, that was, all the funds that were put into the nurses' health study, one, two, three, and all, it is close to $625 million. So you can understand like how enormous amount of time, resource, and everything is being invested. But the outcomes, all the different questions that you can answer through this nurses' health study is golden. Like it's huge. I mean, it gives us so many different new hypotheses, so many new directionalities and all. So it's very useful. So that's why the funding agencies kept funding them for such a long time, and they added new survey items and new quality items and everything over time. So it's huge. The nurses is a landmark study. Okay, so that was about your prospective cohort study. One of the perhaps the most commonly used study design when at least I do my study, I use a lot of retrospective cohort study, where you are here, where this is your present, right? This is you as an investigator, you are here, and all the things that you are trying to understand and establish an association for has already happened. So you are retrospectively looking at it. It has already happened. So for example, let's say that between January 1 and June 30th 2004, we see that no one started using antipsychotic. However, from July 1, 2004 till 31st December 2005 is the exposure period, where in anyone who did not use antipsychotic in the past 6 months, once they start, they get the index prescription, right? They have been exposed to that. Then you follow them up and see what outcome, maybe the same thing, metabolic disorders, if they are developing, but you are not following them up. You are starting at a previous time point. You already have the data collected in different ways, and then you are analyzing them retrospectively to see how the treatment exposure was associated with the outcome that you're interested in. So this is in a nutshell about your retrospective cohort. So if you keep in mind this diagram, it will help you a lot to understand what's going on and how the two different types, the prospective and retrospective cohort study designs differ. So as I said, all events, exposure, latent period, and subsequent outcome, example, development of a disease or a condition, have already occurred in the past. Use existing data, example, the administrative claims database or electronic medical or health records, to identify the study population and the exposure status. And the outcomes of interest or the disease state is determined at present time. As you move forward, you have, let's say, 5 years of data, and you were trying to see from year 1 to year 4 they were exposed and what happens after that. Yeah. So that's how you design your retrospective cohort studies. So what are the advantages and disadvantages of your retrospective cohort study? The advantages is that you can study multiple outcomes, which is pretty similar to your prospective cohort study. So with one drug, you can see many different outcomes. It's much less expensive compared to prospective cohort study. It's not even comparable in many cases. And it is much less time consuming. So this is very important. Like, it can be done or conducted very easily and very quickly. However, there are many different types of disadvantages associated with a retrospective cohort study. There is a problem of selection bias and misclassification or information bias. And later in my presentation, we will touch very briefly on selection bias. Then challenging to assess the temporal relationship. because everything has happened in the past. You don't have any control to assess that temporal relationship. That's a big disadvantage. It relies on others for accurate record keeping. So the consistency of the data, the accuracy of the data is can be questionable in certain situations. Difficulty comparing exposed versus non-exposed, because there can be interchange between them, and may require very large sample sizes for rare outcomes. That's another problem, because if there are certain outcomes which are very rare, you need a very big sample size to see any type of differences that may even be there. This is an example of a retrospective cohort study, which is an original investigation. You can refer to it later on. So basically, it's looking into the serious fall injuries before and after initiation of hemodialysis among older end-stage renal disease patients in the United States. A retrospective cohort study. So I will encourage you guys to read through it and see, how they have designed it, what inferences they made, and all those things. Now, the third and the last type of study design in this observational studies is case control study. And this is very interesting, because how this is designed is very tricky. So the case control studies initiate by selecting subject based on diseases and no diseases. So this is where you are, in the present. So you have a group of people who already have the disease, and you are comparing them to a group of people who do not have the disease. Now, what do you do with them? You go back, all right, and see among the people who were diseased, how many of them were exposed to that treatment and how many were not. You do the same thing for people who don't have the disease, and whether they are exposed or they are not exposed. So this is like a huge deal. Like, so you are going back in time and trying to find out who were exposed, who are not exposed, and you already know who have the disease and who don't have the disease. So you have to review those records in that way. Identify a group of subjects that have the disease cases and who do not have the disease are identified, and then assess the relationship between the risk factor and the disease by reviewing records retrospectively and compare risk exposure in each group. So that's how you really look into that. But case control studies, because of a lot of study design issues, data availability, recall bias, and all, they are not as popular as your prospective cohort or the retrospective cohort studies usually. So, what are the advantages and disadvantages? Advantages: good for studying rare conditions or diseases. So, for example, if there is a very rare disease, it might make sense that you identify that group and compare them to people who don't have the disease, and then go back and see and review their records about who are having a particular exposure versus not having an exposure in the two groups. So that's very useful in those ways. As the condition or disease state of interest has already occurred, this study requires less time, so it's less time consuming. It has the flexibility of assessing multiple risk factors or exposures, the same as the previous two different study design, and relatively less expensive, which is very important. However, as I mentioned before, we have a recall bias. So if you ask me what happened to me in terms of, if I took a medication 6 months or 1 year back, I may not be able to tell you very accurately. So there is a problem with recalling that event. So that's what we call the recall bias. Difficulty establishing temporal relationship. It is almost not possible, like, how and what happened. And sometimes it's challenging to find a suitable group. Like, if you have a rare disease condition, you have to compare it to something comparable. You cannot compare apples to oranges, right? So finding that particular good comparison group or control group can be very challenging sometimes. So these are the different advantages and disadvantages of your case control study design. And this is a very landmark example published in the BMJ, the British Medical Journal, about smoking and lung cancer, carcinoma of the lung, preliminary report. So lung cancer rates were rising in London, and they suspected the cause by coal fire fumes. So they identified the patients with suspected cancer, and found that all patients who confirmed lung cancer were smokers. So smoking was perhaps the main factor, and those and all without cancer were not smokers. So that's why they said that okay, it might not be the coal fire fumes, rather the smoking, which led to this kind of problem, right? So that the smoke, that's how they came up with the idea that that smoking and lung cancer are associated. This is a very landmark study. So, quick quiz question. What do you think is the biggest limitation associated with observational studies? Is it lack of randomization, lack of placebo control groups, lack of strict inclusion exclusion criteria, or lack of large sample sizes? So, in the interest of time, let me give you this answer. And if someone has already answered this correctly, kudos to him or her. So, it's basically the lack of randomization.
Many
Sorry,
of them, many of them have written option D.
D. Yeah, I mean,
Yeah,
D is so observational studies can
yeah.
have large sample.
A written. Yeah, option A has also written.
Okay, yeah, yeah, absolutely. So that's fine. So, but thanks so much for participating. But yeah, lack of randomization is perhaps the biggest issue, limitation, because that's what differentiate between the best evidence versus the second best evidence. So let's quickly compare and contrast between randomized controlled trials and the RWE, real world evidence. So sample size, RCTs have less sample size, pragmatic in the middle, observational has more. Duration, ran, traditional RCTs are moderate, pragmatic control trials takes much more time, observationals are much lower in terms of time or duration. In terms of cost, RCTs are kind of in the middle. Pragmatic trials, as I mentioned before, can be very expensive, whereas observational studies are much cheaper to conduct. In terms of internal validity, RCTs, as you can imagine, has the highest internal validity, right, because of its randomization. And very close next, second comes the pragmatic clinical trials and observational studies. They have much lower internal validity. However, it is completely the opposite when you look at external validity. RCTs are very restricted and cannot be generalized too much. Pragmatic control trial, again, best of the both world. There's high internal as well as high external validity. Whereas observational studies are very generalizable because you are conducting the study population. So that is something in a nutshell about the different types of studies that we conduct to generate real world evidence. Now the question is, okay, we have this evidence. How good or bad is it? So we need to do something of a risk of bias assessment. So in randomized control trial, we answer the question like efficacy, can it work? And we have this component of randomization, which I have been very much, underscoring or focusing on. However, if you look at observational study, you look at effectiveness. So this is a very big difference between RCTs and observational study. So we answer the question, does it work in the observational studies? And we do that in a non-randomized, self-selected way, which introduces the risk of bias, right? Now, the question is, can we mitigate this bias, right? So let's first see what is a bias. So bias is defined as a risk of systematic error or deviation from the truth in results or inference.
Yeah,
So
good
if you
morning. This is Dr.
see,
Krishna. Yeah,
yeah. Okay. So bias is not random error. That is, it's not by chance, and it threatens the validity. So, but the risk of bias is something that we need to mitigate. And as I mentioned before, the selection bias and confounding is perhaps one of the most important things we need to address in our real world evidence kind of studies or observational studies, right? So it is like you remember the baseline characteristics which you measure at the very beginning of the study. So a person who is receiving antipsychotic may be systematically different from a person who is not receiving antipsychotic. So that is one of the reasons, and we don't know why they are receiving or not
Yeah,
receiving that.
Sandipan, Dr. Sandipan, again that sound, can you please adjust?
Oh, I'm sorry. I'm almost done. I will sign off and join right back,
Yeah,
and
yeah.
we should be. Sorry about that.
It is. One second, one second. Yeah, we all said Sandipan. Thank
Okay,
you.
so thanks for your patience. Selection bias. So it's basically, so what I was trying to say is we don't know for sure that why one person received or one group received antipsychotic and one group did not. So if we are comparing antipsychotic users versus non-users and we see the difference in mortality or metabolic disorder, it is bias. There is a selection bias because they may be different in terms of their age, gender, race, ethnicity. So we need to address that selection bias to make the case that our study inference is very valid. There is strong evidence from our.
Hello.
Now, this is like
বলছি আমার
very
ফর্ম ফিল
high
আপ
level
করবো বলছে
overview of how
ইমেল
we
আইডি
can
ফোন
control
নম্বরে
for
ভুল
bias and
ভুল আছে
confounding
অন্য
in
ফর্ম
observational studies.
রেজিস্ট্রেশন করতে
So
হবে
there are many different ways. So regression, analysis-based
যাই হোক
approaches, propensity
আকাশ
score-based matching, using propensity score as a covariate, stratification, instrumental variable, and Heckman sample selection model. So these are some of the examples of how we can control bias and confounding in our randomized control,
ফোন
real world
নম্বর
evidence.
8583
So when you are reading certain research reports or studies, you can
9493
say, okay, if they have done all
91
this kind of adjustments to make sure that whatever evidence is coming out from it is very
700115
strong, right? So this is where it's very important. And then finally, there has been some guidelines and standards for real world
আমাদের বাড়ি
evidence.
দাস আকাশ
So if you
DAS
go through this like standards and guidelines for observational studies, quality is
951
in the eye of the beholder, or standardizing quality assessment of observational studies for decision making in healthcare. So
@gmail.com
you can understand like how and what is going on here, right? How
হ্যাঁ
to address all these things, what to include and what not to do in your
আচ্ছা
observational studies. So this will give you an idea. And why do you need
লিঙ্কটা
that?
ভুল ছিল অ্যাড্রেসটা
Because
ঠিকই
the
আছে
stakeholders could require or enforce methodological standards or guideline because they will not trust if your study has not properly addressed the risk of selection bias or different types of biases within them. Journal editors, when we go to submit our papers in certain big journals like BMJ or JAMA, it is a requirement to say that okay, this particular aspect has been addressed in our study on this page. So sometimes journals ask for that.
ওরাও করে এখন
Funding agencies can require to obtain funding until you can demonstrate that your study is designed well enough. People will not be willing to fund your studies. uh, Center for Medicare or the payers, the third party payers can require to obtain claims data. So, okay, so these are all the different important things. Why are the guidelines and standards and why we need them for the real world evidence? Yes, your real world evidence is very important, very useful, but we need to be very careful how we are interpreting them. If we need to pay very close attention to the study design, right? So, in this way, we can address all these issues. So, having said that, I am ready for questions and
ঠিক
comments,
আছে
and thanks so much for your patience.
দিতে ওটাকা একটু পরে দিচ্ছি ছবিগুলো তো দিতে হবে
Yeah, once again, Dr. Sandipan. Thank
Sure,
you.
please take your time. Yeah, and I know that this is kind of
আগে পরে করে
maybe a kind of a new concept for you guys. I'm happy to address any question or anything like that. So please feel free to ask anything.
Guys, you can write your questions in the chat box directly. And Preeta, you can address. Preeta,
Sir, we
you
have a
can.
question. Yes, sir. Sir, sir, we have a question for you in our chat.
Mhm.
The question goes like, how does the strategy for a case control study differ from that of a cohort study?
Can you repeat that? What was that? Sorry.
Sure, sir.
Yeah.
How does the strategy for a case differ from that of a cohort study?
So I'm really sorry, but you were breaking up. But from so the
Case
way the
study
case,
and cohort study.
yeah, the
People are
difference here.
asking the difference. Yeah.
Yeah, so the basic idea for case control study design is that you have a very rare outcome, very rare disease. So in that case, you cannot really design a prospective cohort or a retrospective cohort study because it will need a very large sample size for them to develop and for us to interpret from there. So that's why we identify them and select an appropriate control group, and we go back in time and see who were exposed and who were not exposed in the disease group, and we do the same for the comparison group, and that's how it differs. For both prospective and retrospective cohort study, we are following them up, but in this case we are going back in time after we identify the disease state. So there is a reverse directionality in terms of time line that happens between these two different study design.
Thank you, sir.
Sure.
So we have another question. What is the best way to collect data from the rural areas of developing countries?
Great question. Great question. So here is where so there needs to be some partnership between the researchers as well as the local government and the central government to make sure that we reach out to this kind of folks, right? And this is a very big issue not only in developing countries, trust me, this is a very big issue in the United States as well. you know so the focus sometimes can be, for example, what is happening in underserved rural areas. Are they getting proper care? How much do they have to drive to a nearest center to get treatment? So what is needed to be done is, like, for researchers to have a passion for that kind of research and develop strategies, like, when you do the data collection, you need to make sure that you address many different aspects to it. So for example, the Nobel laureate, Dr. Abhijit Banerjee, right? So his work was pretty much focused in the rural areas sometimes in certain cases. So we need to address those kind of things and go back, go to those rural areas and make sure that we partner up with the local authorities, and keep collecting data from them and see what kind of treatment they are getting, what are their outcomes, how is their quality of life, and how we can improve them. So this is a great question, but this is how we can address it.
Thank you, sir. So we have a
Sure.
whole lot of questions for you. We are going to email it to you because we are running short on time. So,
Sure.
If you
so
get
we have a
time, please
small
kindly
token of
answer.
appreciation for you.
Sure,
Yes.
sir.
Sure.
Sure, sir. Give me a moment. Yeah.
Yeah. Sure. Yeah. Sure.
The network is a little bit unstable here.
কে রাখে ভাই 35 টাকা ডিম আমার সব বন্ধুগুলোকে আজকে লিখে দিলাম যে এই নম্বরে হোয়াটসঅ্যাপ করবি
Please let me know if my screen is visible.
Yeah, it's starting. So this is for you.
Thank you. It's very kind of you guys for to invite me to this talk, and taking the time and having the patience to listen to my area of research, so to speak. I really appreciate it, and thanks so much. And again, I congratulate each one of you to uh, be able to organize this great session online. So kudos to all of you. Thank you so much,
Thank you.
and I wish you all the
Thank you
best.
so much, sir.
Thank you, Sandeepan.
Thank
Thank
you.
you, sir.
Bye.
Thank you, sir.
Bye. Have a
Bye bye,
good
sir. Bye
day.
bye, sir. Majid sir, shall we proceed?
Saksar, I'll take 1 minute only.
Sure, sir. Absolutely.
Just let me do Professor Hamid as unmute. Then I'll go for YouTube. Yeah, 1 second. Live on YouTube. Um, Day 3. Let's move on. Saksar, we are almost ready.
Sure, sir.
1 second.
Sure.
Yeah, it's done. It's done. Perfect. Thank you. Go ahead, please.
Thank you very much.
Sure.
Can you see my PowerPoint screens?
Yeah, Dr. Hamid, just a second, please. Yeah. Saksar, please.
Yeah. Thank you. Sure, sir. Thank you so much, Dr. Martin, for being with us as a speaker. We are having Dr. Hamid Al Marchand as a speaker of our plenary session right now. So before he starts his presentation on living with COVID-19 and early intervention therapeutic strategy to control the pandemic, I would like to give a brief enlightenment on his professional and educational tour. So Dr. Hamid Marchand is the subject lead in pharmacy and the course leader for postgraduate Institute of Pharmacy programs. His clinical knowledge and expertise in pharmaceutics help students to understand the clinical therapeutic principles underpinning the science of dosage forms, design, and drug deliveries to the gastrointestinal tract. Before joining Huddersfield, Dr. Marchand have been associated with the University College of London, where he investigated various technologies of drug delivery into gastrointestinal tract and offered technical support and expert advice to collaborators and clients from academia and industry on various formulation and drug delivery aspects. On the postdoc assignment at UCL, that is University College London, was to develop a novel formulation for colonic delivery of statins. During this time at UCL, he has also developed a novel in vitro solution for the assessment of pharmaceutical nutraceutical products in physiological relevant condition of the gut. Dr. Hamid was associated with Abbott Laboratories Limited from December 2002 to November 2007 for such a long time and served in various capacities such as quality, formulation, new product development, continuous improvement, and project management. He has been involved in peer review of various research journals. Dr. Marchand is a fellow of the Higher Education Academy, a member of Royal Pharmaceutical Society of Great Britain, American Association of Pharmaceutical Scientists, that is AAPS, Controlled Release Society, that is CRS, and the Academy of Pharmaceutical Sciences, Great Britain. So this was the introduction about our respected speaker, Dr. Hamid Al Marchand. Now I would like to request, sir, if you please proceed for your presentation. The floor is all yours, sir.
Thank you very much for the long introduction. Good morning, everyone.
You're
Today I'm
welcome.
going to talk about the
Good
early
morning, sir.
intervention strategy. Can you hear me?
Yes, sir.
Yes, absolutely. Your screen is also visible, sir.
All right, brilliant. So today I'm going to talk about the early intervention therapeutic strategy to control the pandemic. The idea is to now start living with the disease and hit the coronavirus very hard before it causes a severe disease. So the strategy looks at the early intervention where we offer treatment and therapeutic interventions in the first 14 days of contracting the disease and try to avoid many people going to the severe disease stage. You all have been aware of the pandemic situation now, and now and then we hear about the breakthrough drugs coming out in the press. And currently, as we stand up, there is no confirmed medicinal therapeutic agent yet approved and shown clinical efficacy against coronavirus. The vaccination is still under clinical trials, and it might take many, many months for the trials to finish and the commercial production to be ready. And by the time the vaccine is being offered to the general public, it might take a long time. The disease progression is quite interesting and it's quite alarming as well. Many people are progressing to the moderate to severe disease, which is causing the serious issues with the healthcare system capacity across the world and inability to manage severe patients within the hospital and absence of a breakthrough drug to treat the disease. The number of patients dying are really significantly high, and there is a need for an alternative approach to the vaccine which could control the pandemic. So the idea behind this particular talk or the strategy is to provide an alternative until we get a confirmed treatment or we